Even if you're not an avid sports fan, you've probably noticed the fact that sports equipment has become more and more sophisticated. Often, these changes are meant to improve safety on the field or court. But in spite of these efforts, certain sports injuries, such as concussions, are on the rise for professional, college, high school, and youth athletes. The Centers for Disease Control and Prevention, or CDC, now estimates that between 1.2 million and 3.8 million sports-related concussions occur annually in the United States, and high school athletes sustain over 135,000 of those concussions. In fact, concussions represent 13% of all injuries sustained by high school athletes. These are alarming statistics. However, due to a lack of familiarity with the signs and symptoms of concussions, these injuries have historically been underreported. At Washington Hospital, we understand the problem, and we're committed to making sure that the community we serve is informed about the risks that concussions represent, knows how to recognize them, and understands what can be done to help prevent this form of brain trauma. So today, we're giving you a chance to hear from one of the leading experts on sports-related concussions, Dr. Lawrence Chin, Chair of the Department of Neurosurgery at the State University of New York, Upstate University Hospital. We hope that you find the presentation informative and enjoyable, and invite you to share what you learn with your friends and family.
Well, good morning. It's a real pleasure to be here. I want to thank Dr. Tagyoff, Dr. Larson, Dr. Kunwars, and the planning committee of Washington Hospital for the Neuroscience Symposium. So we're going to talk about traumatic encephalopathy, and just for disclosure, I don't have any disclosures. One of my chief residents has a disclosure slide that says, I have no disclosures, but I'm working on it. So, but we're going to talk about traumatic encephalopathy and concussion, and we're going to start off with just a little bit about what a concussion is, and from that go into how we think concussions develop and what the consequences are of a concussion. So a concussion is something that we talk about, but is difficult to pin down. There have been a number of international conferences that have talked about a definition. One of them was in Zurich, and among the definitions, they talk about a complex pathophysiological process induced by traumatic biomechanical forces. A concussion typically causes acute findings and resolves spontaneously. It's felt that the symptoms are due to functional changes rather than structural changes. But I would maintain that structure is incredibly important because it's really a change in the structure that induces the functional brain change. And the most common symptom is a headache. But as you can see, there are a variety of different symptoms that patients complain of. And that loss of consciousness is not a key part of the definition of a concussion. In fact, you only see it in approximately 9%. So it's a very large public health problem. Probably 10% of all head and spinal cord injuries have some relationship to sports. The CDC has looked into this extensively, over 200,000 ER visits per year from sports head injury. The number of potential concussions, because it's highly unreported, maybe 1.6 to 3.8 million concussions each year. This is in your packet, so you don't have to look at this extensively, but how you assess a concussion can be very important, and the SAC, which is a standardized assessment of concussion, is a very useful tool and something that if you're going to take it into your practice, you can just laminate it and have it available. But it's basically a good cognitive neuroexam, and it's been something that's been shown to be very helpful and pretty quick in terms of making the assessment. So think about what is it that we think puts people at risk for concussion, and some of the preconceived notions that we might have. So here's an example of two football players, and here's a player who has the ball that's driving into the pile here, and he's striking another player who's the defender. And out of these two players, who do you think would be the one more likely to get a concussion? Absolutely. So this, you might think that's the person who's got his head down and going into the pile, but it's this person, and we'll talk about that. This is Tom Harmon, old 98, first Heisman Trophy winner from Michigan. Back in the day of the leather heads with the leather helmets. And I'll pose if you think Tom Harmon is more at risk, or his modern counterpart. This is John Kitna, Cincinnati Bengals. Probably John Kitna, right? Or do you think the guy with almost nothing on his head except for a little piece of leather? Yeah, well, that one's probably pretty obvious. And in fact, there have been studies done looking at leather helmets and how good they are, and they're probably about as good as a modern football helmet. So here's one. This is a high school football player versus girls soccer. Well, this one actually is the obvious answer. High school football is more likely, and it's still the most common cause. But girls soccer is right up there and just behind ice hockey, and probably a little bit higher than boys soccer. Girls basketball is higher than boys basketball in terms of causing concussion. So I think those are things that we'll think about, but are very important in terms of how we educate our kids. Now, if you look at the biomechanics of a concussion, you start off with the classic Newton's second law, F equals ma, and F is the force, m is mass, a is acceleration. So we'll want to keep that relationship in mind. Some of the other things that we think about, stress in the biomechanical world is the force applied per unit area. Obviously, the force is greater, stress is up, but also if you decrease the area, then stress goes up. Strain is a characteristic of the change in length according to stress, and so it's a delta. It doesn't have a dimension per se, but it relates to how something responds to stress. Torque is the angular relationship of force, and this force around an axis, and the resulting acceleration from a torque is angular acceleration. When you look at sports injuries, and soccer is a good example, it's the collision of the heads in this particular case that is causing the force. And so one of the things that can cause a concussion is a focal head impact. So two heads colliding. That causes a direct blow to the head, something that we call a contact injury, and causes a high stress, so a relatively high amount of force to a small area. So where the two heads hit, that's a small area. That causes a local strain in the skull. So the skull deforms, stretches. That may result in a skull fracture. But the underlying brain also has a strain associated with this stress. And the brain can stretch as well. In addition to that, you have some movement. So you have acceleration. So the skull and the brain moves, which causes a translational acceleration, which is a linear acceleration. As a result of this, you might develop a brain contusion. And we talk about coup and contra coup injuries, and that's just an injury on the side of the blow, and the contra coup is on the opposite side, presumably because the forces in the brain move. It can result in hematomas that we see as neurosurgeons. It can result in delayed loss of consciousness, and it can result in diffuse axonal injury. But typically in these focal head impacts, you don't see a lot of diffuse injury. And any changes in consciousness are usually due to the hematoma developing over time. So for instance, in a focal head injury, when two heads collide, you have all these ridges along the base of the skull, and the brain is very sensitive to these, and it scratches against these ridges or hits up against it, and you can get this kind of picture where you have a blow causing skull fracture, an epidural hematoma, contusions on the same side, on the opposite side, which would be a contra coup injury. And this obviously would be a very, very severe example of a head injury. And so in football, what you see is, for instance, in this example, a stiff arm to the face mask, which then causes this player's head to rotate. And this results in what would be described as a low stress situation. So this would be force applied over a large area. You're not hitting a focal part of the skull, but rather you're putting the entire head into motion. And that results in both linear and angular acceleration. And you are, in this type of situation, less likely to see hematomas, but you are more likely to see loss of consciousness. And in a severe case, more likely to see diffuse axonal injury. And why is that? Well, it's because of what we think of as rotational shear injury. And here's a dramatic example in boxing, and why boxing is so injurious. And obviously this person, the key to boxing is to hit the person from the side. You get their head rotating, and that causes rotational and shear energy. And there have been many studies done looking at how much rotational energy you need to cause concussion and increasingly diffuse axonal injury. And as you can see, 15,000, 18,000 radians per second squared, you can get very severe injuries in an experimental model. And boxers typically experience accelerations right in that range. So boxing, obviously, is really the one sport where they've kind of perfected the ability to give someone a concussion as really the goal of the sport. So diffuse axonal injury, if you look at it on an MRI scan, you will see the white matter bundles affected. And in this example here, you can see the corpus callosum with this high signal on the FLAIR MRI image, deep white matter tracts extending down into the brainstem can be affected. If you look at DTI, which is becoming increasingly more useful as a way to look at the white matter tracts, maybe ways to detect very subtle injury in the white matter tracts as a result of concussion. This is an area of active interest. But what you're looking at here is you're trying to look for a physical correlate to the angular acceleration. And we believe that it's affecting these tracts that you can see extend all the way from the cortex and are therefore very vulnerable. Now, there have been many different models of concussion, really beginning with very, very early work. And some of the first work was done by Denny Brown, who was chief of neurology at Boston City Hospital. But he came from England, and in 1940 he published this paper in which he described the brain as a viscoelastic substance in a rigid container, and talked about some of these very early concepts which really remain true today, which is that the brain, when you shake it, causes injury. And so, in fact, if you hold the head in such a way that you don't allow it to be shaken, it can actually absorb a significant amount of injury without causing concussion. And this is his paper where he describes the cat model and how acceleration and movement is the essential factor in the stimulus. And so this idea of acceleration has been around for a long time and was taken by Amaya, who invented the Amaya reservoir that all neurosurgeons are very familiar with. But he also proposed this theory, the centripetal theory, in which he described diffuse injuries caused by rotational acceleration, causing injuries deep in the brain. And in fact, there have been a number of studies that have confirmed that the rotational acceleration does tend to concentrate deeper into the brain, and that, in fact, much of the injury may, in fact, be due to changes in deep brain centers. for instance, a reticular activating formation. And that may be involved in terms of forming a concussion. The other thing that comes out of this idea is that this rotational acceleration it also creates a great deal of shear and stress at the cortex and at the cortex and subcortical interface. And so a number of very interesting studies, and I will show one, have looked at modeling different parts of the brain and trying to model the effects of white matter differently from cortex, from deep gray nuclei, and that the differences in the brain structure can, in many cases, describe what's happening when you put a brain into acceleration. And this is just a diagram showing that when you're looking at the DTI, or the diffusion tensor imaging, you're looking at these tracts, and we think that these white matter tracts, for instance, the corpus callosum, the cerebral peduncle, that these are very vulnerable areas because these are areas where these tracts get tethered, and they're deep in the center of the brain, which is where we would expect a lot of these forces to be concentrated. You know, why is it that when you have two players in football, for instance, and they strike each other, that you see this difference in concussions? And why is it that we think that female athletes are more sensitive? And why is it that we think that younger athletes are more susceptible? Well, a lot of this comes back to really just the basic biomechanics again. And so one of the things that you can look at is, for instance, if you take two football players, the one player who has his head lined up with his shoulders and is striking another player, possibly from the side or a glancing blow. If we assume that the forces are going to be equal, because the one force is going to be applied to the other force, which is the one player hitting the other player, then we have where the mass and acceleration must be equal. Well, if you have someone who's coming in with a very effective, high effective mass versus a player who's not prepared for that mass and that force, well, then if the masses are different, then the accelerations must be different. And as a result of that, the acceleration of the player who's getting hit becomes much greater. Same thing if you have a situation where you have typically a high school athlete who is less developed, or female athletes where the neck muscles are less well developed. The head is not as stabilized. As a result of that, you're going to see a much higher acceleration in those situations. And that's why we believe that those populations are much more sensitive to the effects of concussion. Well, this is a study that was done using finite element analysis, in which the different parts of the brain were modeled, including the dural structures, vascular structures, and then they modeled impact data from watching NFL game films and tried to predict, based on this model, where you would see the injury. And here's just an example of one particular model where a player was struck from the side. And when you look at the strain, and again, remember the strain is the deformation of the brain in result to the force, you see that the strain initially is experienced right over the side of the blow. And then as time develops, you see strain on the other side. So that's the contrecoup injury. And then the last part of the injury then is concentrated more in the brainstem. And so these kinds of studies have been very interesting because they can model what we believe is happening and also explain some of the things that we see. So to recap this part of the biomechanics, we know that boxers experience low translational but very high rotational acceleration. and that we know that younger athletes experience greater velocity and acceleration, and that girls are at greater risk. And so one of the key things that we have to think about is what's going to be the response of the head to the blow. Well, I want to talk very briefly here about some of the metabolic changes, because there are probably some metabolic changes that are occurring with concussion. We know that one of the initial changes that you see when a neuronal membrane is disrupted is that there is a release of potassium into the extracellular space. And this buildup of potassium can cause release of excitotoxic amino acids, for instance, glutamate. So glutamate isn't just in Chinese food, it's in your brain too, which is probably why Chinese food tastes so good. But we know that glutamate binds to the NMDA receptor. And glutamate, while a transmitter for learning and memory, also causes depolarization of the membrane, and you get these fluxes of ions with potassium going out, sodium and calcium going in. This depolarization probably causes some neuronal depression, which may explain some of the symptoms of concussion. And the result of this change in the ion shifts is that there's an increase in metabolic demand, an increase in the activation of the sodium-potassium pump. Another thing that happens is the calcium builds up in the cell. This calcium buildup in the cell probably results in some injury, both to the mitochondria, so it affects energy production in the neuron, and also probably causes some direct injury to the cytoskeletal structure. So the axon itself is being affected. The sodium-potassium pump is a pump that requires energy, and so because you have to rev up this pump, the brain is requiring an increased amount of ATP. This is going to result in metabolic downstream effects. Lactate can build up, and this could affect cerebral blood flow. The cerebral blood flow changes can result in neurons not getting enough blood when they need more. There are some later changes in which the blood flow goes down. So you can see it becomes a very complicated story. And so kind of the bottom line to all this is that if you just look at the biomechanics, it's not too complicated. Then you add in the metabolic changes, and there are further layers of complexity to this entire story. And so that's just a little description of what we think is happening when the brain is injured, which results in a concussion. Well, one of the interesting questions that you might think of is, why are there certain animals in nature that seem to be professional headbangers? For instance, woodpeckers, someone wrote, why don't you see woodpeckers lying on the forest floor, basically in the constant state of concussion? And why do rams, for instance, seem to be able to engage in these mating displays and they don't knock themselves out? Well, I don't think anyone really knows the answer, but there are a number of things that have been postulated. We do know from comparative anatomy that woodpeckers, for instance, have very thick, dense skulls. There is a thought that they have a muscular structure that allows them to stabilize the head and perhaps dissipate the impact, but obviously you can't soften the blow because then the woodpecking is not as effective. It also appears that woodpeckers have very tightly encased brain with very minimal subarachnoid space, so that there's relatively little room for brain shaking and shearing. And when you look at the anatomy of birds and certain animals, the entire brain and brainstem are very linearly oriented, so that perhaps there's less of the stress placed on that junction from stress. So I think the bottom line is there are certain animals that are very well designed for hitting their head, but unfortunately humans are not one of them, and that brings us to this discussion of chronic traumatic encephalopathy. As you probably know, this is a very, very hot topic. You probably can't go a week without having some front page news story I think the most recent one is Junior Seau, and I think finally they've decided they're giving their brain to the NIH. But this is an area of heavy media interest for obvious reasons. This is Dave Duerson, All-America safety from Notre Dame, played for the Bears. Daryl Johnston, who was a fullback for the Dallas Cowboys, who actually, not known for having a concussion, but had an ACDF done and actually played football with an anterior cervical fusion. But Dave Duerson, very decorated football player, Pro Bowl safety, won 2 Super Bowl rings, but had a story that we are now finding is all too common, which is after football, he had personal bankruptcy. He had a great deal of personal problems, divorce, lost his house, and then he committed suicide by shooting himself in the chest, which is sadly something that we've seen many, many times now amongst these players. And in his suicide note, asked to have his brain donated to the Boston University Center for Study of Encephalopathy, where the presence of CTE was confirmed. This was really the first study that described traumatic encephalopathy in a football player. This is Bennet Omalu, who did an autopsy on a famous football player in the Pittsburgh area and a few other cases, and described CTE. But CTE is something that's been around for quite a while. This is Harrison Martland, who described the punch-drunk syndrome. He was a medical examiner in Newark, New Jersey. And he wrote this paper, I want to say 1920-something, where he described the punch-drunk syndrome. And you have to love papers from this era because you don't write papers like this anymore. And so I always love the description here of cuckoo, goofy, cutting paper dolls, slug nutty. I just somehow, it must have been so much more colorful in the 1920s. So we've lost that, unfortunately. But we have Facebook now, so we're better off. But this is an example of autopsy findings of cases of traumatic encephalopathy in boxers. This comes from a different study. But you can see some of these things, the cavum septum pellucidum, the diffuse atrophy, as being things that when we look at the brains of traumatic encephalopathy sufferers, these are the exact things that you see. Degeneration of the substantia nigra. So that obviously can cause Parkinsonian symptoms. Muhammad Ali is a prime example of that. Cerebellar scarring, nerve loss, changes in the mesial temporal lobes, mammillary bodies, certainly affecting memory and cognitive function. When you look at microscopic features of CTE, I would say that you see neuronal loss and gliosis, but the key feature is this tau, which is the predominant tau protein in neurofibrillary tangles. And you see that in virtually every case. It tends to have a slightly different appearance than in Alzheimer's. It's in more superficial layers of the cortex. You see amyloid plaques in CTE, but it's not as common, and you don't see it as prominently as in Alzheimer's. But there does seem to be association with ApoE4. This is an example of a normal brain. This is a patient with CTE, and the brown staining is the tau protein, and you see it very heavy staining in the hippocampus, mesial temporal lobe. You see it in the cortical sulci, particularly in the depths of the sulci. This is normal. You should not see tau in a normal patient or normal person. John Grimsley, another typical sad story, multiple concussions prior to dying at age 45, a worsening memory, cognitive function, also died of a gunshot wound to his chest. Initially, they didn't think that this was suicide, but I think we've got to reconsider many of these things. So this is an example of a normal control. This is John Grimsley's temporal lobe, and you can see the very heavy tau staining. And this is an old boxer with dementia, so you can see how much these changes develop over time. So what we know about tau in CTE is that it's not a part of normal aging. It tends to get worse over time, so it's a progressive disease. It's worse in patients who have more symptoms, but not every athlete has been shown to have tau. So we don't know what the natural history is of CTE. We think it's related to axonal injury, but there are no good animal studies on this. And so is tau a marker of disease, or does tau actually have some neurotoxic effects? There's another association that's very interesting, which is that between CTE and ALS, or motor neuron disease. Lou Gehrig, interestingly, before he was a baseball player, suffered many concussions as a football player. So there's some significant circumstantial evidence that people who have suffered more blows to the head may get ALS. And there have been 3 cases of ALS in athletes who also had CTE that were studied by our group at Boston University, and found to have tau and another protein called TDP-43, which is something that you see almost exclusively in the brains and spinal cords of patients with ALS. And so TDP is a protein that binds mRNA and may play a role in the injury response to neurotoxicity. And so here are some slides that show tau, and you can see just in higher magnification the amount of tau in 3 different patients that had CTE and ALS. But you also see TDP-43. And here you can see the red is TDP-43, the brown is neurofibrillary tangles of tau. And so in the spinal cords, you can see tau in the anterior horn cells of these patients, and also you see TDP-43, which is on all these red structures. So we definitely see a significant amount of CTE now, and these are just cases, and I'll just bring your attention that, we don't know about Junior Seau, but he disturbingly fits a pattern that we've seen many times in football players. So what can we do about this? And I think I'll show you this because this is Pop Warner football, and I think these are the kinds of things that we have to really think about as physicians, healthcare professionals, nurses, trainers, and parents, because we don't know really what the effect is of all of this repeated blows in our young athletes. I'm going to skip over this. This is the Cantu concussion grade. It's going to be in your packet. But there has to be a great deal more attention to what we can do, which is when we treat a concussion, which is to take a player out of the game. And I think one of the things that needs to be done is the recognition of concussion and the fact that if you suspect a concussion, you have to be removed from play immediately. And you can't return that day until you're assessed by someone. In the NFL now they have people in spotters in the booth to look for concussion so that people don't come back into play. Part of the treatment is total cognitive rest, and that means no reading, no TV, no computers, because all of those activities activate the brain and slows recovery. This little slide is in your packet as well, but describes what the return to play protocol is. And it's a graduated return to play protocol. And I think that that's something that is important to understand and to follow so that kids are not rushed back. And so the basic idea is that it's graduated. You start with very light activities. You start off with light aerobic activities. Aerobic activities will bring out symptoms of concussion. So somebody might be fine at rest, but you put them on an exercise bicycle or you ask them to do jumping jacks, and they start getting headaches and they start feeling sick. And so it's very important that, that any return to play be monitored. And I think we need to identify these concussions early. It's well known that the first concussion increases the risk of a second concussion, and that there is a risk of having repeat concussions. And one of the biggest risks is the second impact syndrome, which I'm not going to talk about, but typically occurs in our young athletes and is a catastrophic brain swelling that you will see sometimes with a very trivial second injury. Another very important thing that we don't think about is all of the blows to the head that occur in practice. And so you can regulate games, but practices are always unregulated. And 50% of hits in football, for instance, will take place during practice. So all of these things really kind of speak to the need for some changes to take place. And there was a time when football also went through very significant changes, and that was in the early 1900s, when there were many, many injuries and fatalities in football. And some of the rules during that time, such as gang tackling, and the flying wedge formation, where basically you had a group of athletes form a wedge and you protected the ball carrier who's behind them. And in fact, there were descriptions of football games, a Harvard-Yale game, where the Harvard team was in the flying wedge, and they described how this wedge basically went around and systematically picked off the Yale defenders. And so because of these changes, Teddy Roosevelt, who was president at the time, became involved. And in fact, if you read about Teddy Roosevelt, he played a very significant role in football during this time. And in 1905, he called for reforms in a year where there were 18 deaths from football. And things like gang tackling and the flying wedge were outlawed. They developed the forward pass, to the delight of the San Francisco 49ers. And the NCAA was formed. And so changes were made in the sport. And I think that we may be at a point where we may need to think about how can we make this sport safer. You probably know that there's a big class action lawsuit of NFL players against the NFL stemming from concussion and all the after effects of concussion. So I want to end with just a little plug for my former group at Boston University, where the CST Brain Bank was started. They have over 800 brains that have been donated. And I can tell you that the cases that have been released are just a small number. And not every single athlete has had CTE, but almost all of them have had it. The youngest case is an 18-year-old. And these are my colleagues at, when I was in Boston, Bob Cantu, who is really kind of the dean of CTE and sports concussion, Bob Stern, Ann McKee, who is a neuropathologist that did all the neuropathology studies, and Chris Nowinski, who is a former Harvard football player and pro wrestler. And these are really the people that spearheaded the development of CTE. So I just want to end by saying that I want to thank you for inviting me. I think this is an area that is of intense interest. It's a very important public health problem. It affects, I believe, every one of us. And I think we all have the capability of intervening in a meaningful way. And we've got to promote education about this particular problem. Thank you.
Thank you very, very much.
Thank you.